Dr. Karen Choi is an assistant professor at the University of Michigan in Ann Arbor. She has been in Detroit for a long time. She did her BS. She received her MD. She did her APCP residency, followed by a GI and liver fellowship, all at University of Michigan. Dr. Choi had 3 grants to her credit and two past grants. She does a lot of research. She is very well published, mostly in the area of gastrointestinal and liver pathology. She received several teaching awards and serves as a reviewer for several distinguished journals. As I mentioned, her CV is quite impressive in the number of her talks and publications, considering her relatively short career so far. But she's a very productive gastrointestinal pathology, and we are happy to have you here with us today, Dr. Choi, to tell us about new advances in gastric adenocarcinoma. All yours now.
Thank you so much for the very kind introduction. My topic today is noted as gastric adenocarcinomas. If for any reason you can't hear me, please let me know, and I will see what I can do. I'm going to be providing a review and updates regarding classification systems and subtypes of gastric adenocarcinomas. Just information on the current biomarker testing for gastric adenocarcinomas and syndromes with an increased risk for developing adenocarcinomas. So starting with the epidemiology, gastric cancers vary quite widely in terms of incidence, depending on a geographic region. The majority of gastric cancers worldwide come from Asia, Central Eastern Asia, more specifically Eastern Europe and South America. These, as you can see here, constitute the majority of the cancers. In North America, we only see a small number relative to the rest of the world. In terms of risk factors, about 90% are sporadic, whereas 10% have some hereditary germline mutations. For the sporadic types, H. pylori constitutes the bulk of the causes of environmental risk factors for gastric cancer. We have the typical sort of superficial gastric inflammation here with areas of atrophy in which there's loss of the exanthic mucosa, intestinal metaplasia, and in this background, adenocarcinomas can arise. So I was just saying that about 90% of gastric cancers are sporadic, the bulk of which are from H. pylori infection. Others have established risk factors, including tobacco smoking, rubber manufacturing industry workers, and X-ray exposures. In terms of classification system, currently the WHO recognizes 5 different types in the most recent edition of the classification of digestive system, or I'm sorry, tumors. And these include the tubular, papillary, poorly cohesive, mucinous, and mixed cancers. Previously in the Lauren classification, which is still used, but less so now, the 2 main classifications were the intestinal and the diffuse types of gastric adenocarcinomas. Currently, the tubular and papillary types are included in the intestinal type. And then what used to be called diffuse is now referred to as the poorly cohesive type of gastric adenocarcinoma. Mucinous carcinoma is now a new classification category that's separated from the other 2, and then tumors often have a heterogeneous morphology and are considered to be mixed tumors. So a little bit about each of the 5 types that the WHO currently recognizes. This is the standard tubular adenocarcinoma, formerly called the intestinal type. It's the most common subtype of the gastric adenocarcinomas worldwide. And these have tubules, they form lumens, some of which can be slit-like or dilated. And the poorly differentiated type, which were previously considered indeterminate, where they have mostly a solid growth pattern and foci of barely recognizable tubules, those are now classified also as tubular adenocarcinomas, but a poorly differentiated type. The papillary adenocarcinoma is another well-differentiated adenocarcinoma. It's really hard to actually find photos in literature of this. And so here's one example in which there are these villi, and the villi have fibrovascular cores, which set this apart from a micropapillary type of carcinoma. These usually have an exophytic growth pattern, tend to be somewhat larger. These finger-like processes are present, but there's no minimum percentage requirement to call it a papillary adenocarcinomas. In studies, some use 50% as a cutoff in their study, others will use 10%. But regardless of percent that was used in the study, most studies suggest this may be an aggressive growth pattern despite this well-differentiated appearance. And these have frequent LVI or lymphovascular invasion, the submucosal invasion, lymph node metastases, liver metastases have all been reported with some of these early gastric cancers that have this morphology. So there's some degree of concern as to whether these are adequately treated when they're early stage, meaning just mucosal or submucosal. Treated with endoscopic resection. And one of the more recent studies suggests that a complete submucosal dissection, which is not commonly done here in the States, would be sufficient to treat these types of cancers. But jury's out still as to the exact behavior of these cancers, as they are rare. The poorly cohesive cancers are the ones that used to be called the diffuse spreading types of cancers. These include the Signet ring cell carcinomas. They're the second most common type of gastric adenocarcinoma. They occur with either single cells, small aggregates. Sometimes they form somewhat poorly appearing tubules, but no really well-formed glands. And when it's composed predominantly or exclusively of these signet ring type cells, which have the eccentric nuclei and mucin vacuoles. They're categorized as signet ring cell carcinomas, a subcategory of this poorly cohesive carcinoma. Many of the cells oftentimes, however, will not have this signet ring morphology, but rather instead of mucinous cytoplasm, just eosinophilic or amphiphilic cytoplasm. They can mimic inflammatory cells. And when predominantly composed of that type, it's simply just considered a non-signet ring cell type or just poorly cohesive subtype of gastric adenocarcinoma. This is the type associated with linitis plastica when there is a diffuse gastric infiltration by these cancers. And when it's associated with desmoplasia, it creates thickening and firmness of that gastric wall, which gives it the rigidity of a leather plastic or leather bottle appearance. And these are more prone to peritoneal metastases as opposed to a hematologic spread of the tubular types of adenocarcinomas. In terms of differential, it is important to consider that there are mimics of this poorly cohesive type, and we've seen them not infrequently here. One is the lobular breast cancer. That's the most common mimic we see. The tip-off being that they tend to be very uniform, as opposed to the gastric types, which as in pictured here, have more of a pleomorphic appearance to their nuclei. However, that alone is insufficient for the diagnosis. If you see clear signet ring cells, that would be very unusual for a breast cancer and is most likely to be a gastric carcinoma. But a limited panel can be helpful, especially if there is no history or if there is a known history of lobular breast carcinoma. And those include GATA3 and ER, which will be usually positive, and CDX2 will be negative. Although these don't have an intestinal type appearance, these mark with CDX2, and so that can be helpful in the differential. The other variant we've seen is a plasmacytoid variant of urothelial carcinoma come to the stomach and mimic a gastric cancer. They too will be GATA3 positive, but ER negative and CDX2 negative. Sometimes clinical history is not available, so it's always good to keep it in the back of the mind, as we've had patients sometimes either referred here for gastric that actually have lobular, or patients who just had an undiagnosed lobular breast cancer, and the first place they discovered it was stomach. In terms of mucinous adenocarcinomas of the stomach, this is an uncommon subtype, and the WHO defines this as having greater than 50% area of extracellular mucin within the area of the tumor. And this mucinous area will contain epithelium of the carcinoma in two different patterns. The first is a tubular pattern in which you have tubules, but then there is associated extracellular mucin. And then the other is the more conventional look of small clusters of epithelium that are malignant, floating in pools of mucin. And it's the latter type that appears to have a different molecular profile than the types that have just tubular morphology with a lot of extracellular mucin. In terms of adenocarcinoma subtypes, there are various other ones that have been reported in literature and are included in the WHO as additional subtypes. Of those listed, the most commonly encountered is the gastric carcinoma with lymphoid stroma, also known as medullary carcinoma or the lymphoepithelioma-like carcinoma. These are commonly associated with EBV infection, which can be demonstrated by the Eber-ish. MSI or MMR deficiency, so loss of the MMR proteins can be demonstrated in a small subset as well. And with these, there are these irregular nests of carcinoma cells associated with both lymphocytes within the tumor cells as well as in the stroma around the tumor cells. There are other variants such as hepatoid adenocarcinoma, which have overlapping features with HCC, adenocarcinomas with enteroblastic differentiation, which have clear cells and look like fetal gut, and then micropapillary adenocarcinomas, which are thought to have a more aggressive clinical course with lymph node metastases, and then the gastric adenocarcinoma fundus gland type, which is very rare, but has carcinoma cells with morphology resembling fundus gland type cells like parietal and sheath cells, and those are reported to be more indolent, but again, very rare. In addition to the WHO classification system, there are others in use as well. One that's commonly used in the Asian populations is this Japanese Gastric Cancer Association classification system, again, based on morphology. There are also molecular classification systems, one of which is the TCGA proposed classification, in which in their analysis, they identified 4 different subtypes, EBV infected, MSI high, the chromosomal instability type, and the genomic stable subtypes. These do have some morphologic correlates. The EBV, as mentioned before, has often a medullary type morphology. MSI can be detected with the immunohistochemical stains or MSI testing molecularly. The CIN type tends to be the intestinal or the tubular type, and then the diffuse or the poorly cohesive type are the types reported more commonly with the genomic stable subtypes. At this time, the molecular classification is not in use clinically here, but there is interest in what this may be able to inform in terms of prognosis and therapy. In terms of prognosis, although the morphology can help inform what characteristics might look aggressive or how the tumor might behave, the most important prognostic factor is the TNM staging. And this study here nicely showed that the current TNM staging with our AJCC 8th edition really stratifies these survivals in patients well based on the T stage and the N stage, here being the T4 and here being T1A. And so this is really the most important factor when looking at these gastric adenocarcinomas. In terms of the differential diagnosis, important to consider adenocarcinomas that are metastatic or directly extending into the stomach, as they will have different therapies. The WHO has a newly defined category they have a chapter for called the undifferentiated carcinoma. Neuroendocrine neoplasms can sometimes mimic adenocarcinomas, and they can either be the well-differentiated neuroendocrine tumors, formerly carcinoid tumors, neuroendocrine carcinomas, or the mixed type of tumors that have an endocrine component and a non-endocrine component. Adenosquamous and squamous cell carcinomas, pure squamous cell carcinomas have been reported but are very rare. And gastroblastoma is also a new entity included with the most recent WHO. These are biphasic tumors. They have epithelial as well as spindle components. The epithelial component will mark with keratin, whereas the spindles will not. And a gene fusion has been identified, the MLA T1 and GLI1 fusion. As I mentioned, the adenocarcinomas that are metastatic to stomach are important to consider for ones where you see tubular differentiation, The most common that we've seen here is pancreatic cancers that are infiltrating from the outside of the gastric wall in and up into the mucosa. As you can see here, they don't have much of a desmoplastic response, but they do have a more pink cytoplasm, and they have what has a more pancreaticobiliary morphology compared to the intestinal morphology of most of the gastric tubular adenocarcinomas. This can be a tip-off that we're dealing with a non-gastric primary. There's no stain to differentiate it in this case. It will have to be done radiographically, given that there's a mass usually in the pancreas that will be detected on imaging. HCCs can also metastasize to stomach and would be a consideration when considering hepatoid types of adenocarcinomas. And you can see here a small collection of HCC cells within the mucosa. Many other cancers can metastasize to the stomach as well. In terms of the undifferentiated carcinoma category, WHO defines these as being composed of anaplastic cells showing no specific cytologic or architectural differentiation. Glandular component, they say, however, can be found if extensively sampled, suggesting a de-differentiation of an adenocarcinoma. These have an aggressive clinical course. Most will present with metastases or develop them soon after their diagnosis. And many patients will have poor survival. The switch-SNF chromatin remodeling complex has been found in some of these cases of undifferentiated carcinoma. This is a large complex with many subunits, of which some of them are the SMARC A4, SMARC B1, ARID1A, and these can be have loss of function. The carcinomas histologically can be composed of these diffuse sheets of undifferentiated looking cells. They can at first make it uncertain whether this is a carcinoma, whether you're dealing with a lymphoma or some other kind of cancer, but they sometimes will have, actually quite commonly within the tumor, an area that looks rhabdoid. And so here's an example. It has more pink cytoplasm and eccentrically placed nucleus here. And this can be one feature that can make you wonder if maybe this is one of these undifferentiated carcinomas that can have loss of one of those proteins mentioned, and that can be demonstrated by immunohistochemical stains, which I will show you in the next slide here. But other patterns have been reported as well, spindle types, some with associated osteoclasts like giant cells, and others with a medullary type appearance with a lot of lymphoid stroma. There's variable expressions of pancytokeratin, and shown here most of these cells not staining with pancytokeratin, but focally staining. And then the immunostains are SMARC A4 and B1 are also available, but up here you can see there's loss of the nuclear staining, whereas in the background internal control, the staining is present. IHC can help exclude other neoplasms, such as medullary carcinomas that are EBV associated, lymphomas, melanomas, and sarcomas. In the biomarker testing category, currently HER2, MMR, and MSI are the types that we use more routinely for the gastric cancers. Newer is the PDL1. However, as I will note in a slide later, it looks like this may not be that helpful in gastric cancers currently. So it's uncertain as to whether this will continue to be used in that context or exactly how it will be used. These biomarkers are indicated really only for the advanced type of gastric cancers. These include the unresectable, locally advanced types, recurrent gastric cancers, and metastatic gastric adenocarcinomas. And it's recommended if there's metastatic disease that is documented or suspected, and it helps determine therapeutic regimens. In some centers, they're done sort of reflexively, and that's what our oncologists here have asked us to do. And so we often do these at time of diagnosis per their request. NGS or next-gen sequencing can be performed. It's not considered to be first line. The NCCN guidelines ask that the IHC for HER2 and MMR be done first. If there's very little tissue, additional testing with the NGS can be done actually first to look for other biomarkers, including this high tumor mutational burden, NTRK fusions. HER2 amplifications can be detected as well as MSI and MMR, but that is considered to be testing only after these other tests are done, if possible. Trastuzumab is a therapy for the HER2 positive cancers. And in this TOGA trial, the HER2 IHC or by FISH demonstrated gastric adenocarcinoma is having about a fifth, 22% with HER2 positivity. Of these, most of these that are HER2 positive are the intestinal type. It's uncommon to see them in the diffuse type, but they reported in their study seeing them in 6% of their cases. And the prognostic significance of this HER2 status at this point is debated and unclear. Mostly it's used right now to direct therapy for gastric cancers. And so this is the most commonly used scoring system as outlined here. And it's very similar to the breast cancer scoring system with two exceptions. The first is that in a biopsy specimen, there's no percentage requirement. It's actually the minimum requirement is very low. It's just 5 neoplastic cells, which they call a cancer cell cluster. And so it doesn't really take a lot to get to a 2+, because all you need is weak or moderate staining and just 5 cells, which is considered a cancer cell cluster. In addition, a full membranous staining is not required. It can be present, but the real common denominator in positive staining is the lateral staining. So it can be full membranous staining, just the lateral staining, or the basolateral plus membranous lateral staining. And all of those patterns will count as a positive staining within a tumor cell. If, as with breast, it's 0 or 1+, it's considered negative. And then with 3+, it would be considered positive. 2+ FISH is available with a separate scoring system from breast for determining amplification of HER2. In terms of caveats to consider when interpreting the IHC, the displayer can actually stain quite strongly, so it's good to have an H&E for comparison to make sure that you're evaluating the invasive carcinoma and not background dysplastic. Admittedly, at times when there's a lot of cancer and high-grade dysplasia, it can be quite difficult to determine whether it's high-grade versus intramucosal invasive carcinoma. So I try to stay away from those areas and look for areas that are more clear-cut. And if there's any question, they can be sent for FISH testing, although same would apply with the FISH testing to look at the invasive and not the precursor dysplastic lesion. In terms of cytoplasmic and nuclear staining, we do see it with the clone we use here sometimes, and it can be seen. It's considered nonspecific as it is in breast, and it can be a little confusing because it can be hard to tell if there's any membranous staining when there's a lot of cytoplasmic. Those also often get sent for FISH if there's uncertainty as to whether it's positive or, negative or equivocal. MMR and MSI testing are done with the intent of using checkpoint inhibitors. The pembrolizumab has been approved as a second or subsequent line therapy for gastric cancers that are metastatic. And if there's microsatellite high or deficient mismatch repair in the gastric adenocarcinoma, patients can receive this therapy as they can for many other solid tumors. Mismatch repair we do with the IHC, and then if there's sufficient tissue, the MSI can be sent, although there's good concordance between the two. So oftentimes, if there's limited tissue, we just do the MMR staining. In terms of a PDL1 staining, this has become an area of great interest for a lot of solid tumors. And it's confusing because there's many different clones. The assays selected will depend on the primary site and the intended chemotherapeutic agent that they're looking to use. With these regimens, they have different interpretive scoring systems, mainly a TPS, which is mostly used for lung, is the tumor proportion score. The common combined positive score, or CPS score, is what is used with gastric cancers. And then there's the tumor infiltrating immune cells, which is used in some cancers, such as certain breast cancer assays. And then the cutoffs of the positive scores and what's meaningful as a positive score will also vary depending on which tumor type and which therapy is being considered. The PD1 and the PDL1 interaction is normal within the cells. As a simplified sort of explanation, the cytotoxic T cells and other immune cells have a receptor that's called the programmed death 1 receptor, and it will interact with the ligand, which is present normally on most of our human cells. And it identifies cells as self and allows the immune system not to overreact and will sort of downregulate this immune response. However, tumors can also express this PDL1 and therefore sort of disguise themselves as being a normal cell. And so the immune system may not react vigorously towards the tumor cell. And it is with the intent of detecting these cancers that can express these ligands that this assay is done. And so with the gastric cancers, we look for both the the membranous staining within the tumor, as well as immune cells out in the stroma. The reason is that with therapies such as Keytruda or pembrolizumab, it will block this interaction by blocking this PD1, the receptor here. And so this interaction cannot occur. With this PDL1 assay, again, with the gastric cancers, the CPS score is used. Technically, you could get a score greater than 100, but by definition, the maximum is 100. What we do is we look for the immune cells that are within the vicinity of the tumor at a 20x magnification, and they can highlight lymphocytes, macrophages, and you add those together with tumor cells that have the membranous staining, which can be, it doesn't have to be complete, it doesn't have to be strong, it can be just any degree of membranous staining in a tumor cell, and we combine that all divided by the total number of tumor cells times 100. And with that score, before, it used to be that with a CPS score of 1, which is really not hard to get to oftentimes, it would allow patients to be treated with pembrolizumab. And so we were doing this, but as of July, Merck, which makes this pembrolizumab, actually voluntarily withdrew their accelerated approval indication with the CPS score of greater than 1 as a third-line therapy. The reason being that they did not meet the indication. It said they did not show an overall survival benefit in a phase 3 study using this cutoff. And so the NCCN guidelines did take that into account with the most recent guidelines they issued and took this out of their recommendations. However, it's sort of a mixed bag. If you look in the NCCN guidelines right now, they still have mention of using the CPS scoring. And so at this point, it's a little confusing as to the actual indication of whether we need to do PDL1 testing at all in gastric cancers. They do actually include a CPS score for nivolumab, but presumably it's a different clone. They don't actually specify in their guidelines. Currently, this is indicated for head and neck, bladder, and lung cancers. And they use the clone 28A rather than the 22C3 that was used for the CPS score of 1. So again, rather complex. It's unclear as to its actual role in gastric cancers at this point. There are emerging biomarkers, including the EBV, viral-related gastric cancers. These constitute about 10% of gastric cancers. Studies suggest there may be a better overall survival, and they may have an increased sensitivity to the PD1 and PDL1 immunotherapies. However, there's a lack of prospective trials, and the exact association is unclear between the viral infection and gastric cancer development. And so currently it's not recommended for routine care. We tend to use it when we see the medullary morphology and want to see if there's EBV associated infection with it. For the rest of the lecture, I would like to talk about the syndromes that are associated with increased risk of gastric adenocarcinomas. And there are many syndromes that have just generally increased risk of cancer, some of which I won't cover, such as Lynch syndrome, Li-Fraumeni, Muth, H syndromes. But there are others that have gastric polyps and an increased risk of gastric cancers that I wanted to discuss. And these include the FAP, the Poytz-Jaeger syndrome, and juvenile polyposis, all of which are well known, but not much talked about in terms of gastric cancers. And then there's the gastric adenocarcinoma and proximal polyposis of the stomach, or GAP syndrome, which is fairly recently described. And then the hereditary diffuse gastric cancers, which we're seeing a lot more of here at our center now. For the familial adenomatous polyposis, or FAP, the germline mutation is in the adenomatous polyposis coli gene, which is a tumor suppressor gene. There's an autosomal dominant pattern of inheritance. And in terms of gastrointestinal manifestations, well known are the chronic adenocarcinomas that develop in the context of numerous adenomas. Patients often get colectomies. There's surveillance for small intestinal adenomas because they can develop often in the duodenum and ampullary areas. And in the process of surveillance in these patients, we often get gastric polyps that are biopsied in these patients, as many of the patients will develop gastric polyps. Most of these gastric polyps in our Western populations are fundus gland polyps. About a third of these have low-grade dysplasia, so it's actually quite common to see low-grade, although the low-grade can be quite subtle and actually make it difficult to determine sometimes if it's reactive versus truly low-grade. The difference between the two is probably not significant because there's a really low rate of progression to high grade and really not very good information regarding its actual potential to develop cancers within low grades developing in fundus gland polyps. About 20% of polyps in the Western population are adenomas. Most of these will be the foveolar type, which is also thought to have a lower rate of progression than other types of adenomas in the stomach, such as the intestinal type. And the pilar gland adenomas have also been described. The intestinal type is rare in the Western populations, but in Asian populations, there's a higher percentage of patients who will have adenomas, about 40 to 50% of those polyps biopsied are adenomas, and these include the intestinal type. Whether it's for that reason or for another, in the Asian populations, they've reported a much more likely risk for progression to developing gastric cancers. They say 7 to 10%, and I'm sorry, not percent, but times more likely in some studies than non-syndromic patients. Whereas in this Western population, we don't see cancers developing oftentimes. So treatment is very conservative, biopsying maybe the largest polyps or just any suspicious looking areas, or just randomly sampling as they have a very low risk of progression. This is one case we saw of a resection of FAP. This is the stomach here, and you can see it's just covered by innumerable polyps. This is the fundus. It's covered just throughout the whole stomach, all the way to the antrum here. On sectioning, you can see a lot of polyps. Most of these are all fundus gland polyps. And some of them, again, did not have dysplasia, whereas others did have dysplasia. And it's just a little bit darker at lower power. The architecture is a little stranger. Higher power view showing elongation, crowding. Again, ones like this will probably not get very good inter-observer concordance as to whether it's dysplastic. But compared to most gastric fundus gland polyps, this degree of atypia is a little bit much for a fundus gland polyp. But again, in the Western populations, probably not a very significant finding. This is another area from this patient where it wasn't as well developed. There is a little bit of dilation here in some of the exinthic glands, but some of them kind of have a morphology somewhere in between an adenoma and a fundus gland polyp, but it is dysplastic and is low grade. This patient had the resection because they developed an adenocarcinoma, and in the background, it looks like a foveolar type of adenoma, but they can occur, just not very common. Related to this is the GAP syndrome. Initially, this was thought to be a separate entity. Currently, many consider this to be a variant or a special type of FAP. And in these patients, GAP stands for gastric adenocarcinoma and proximal polyposis of the stomach. it was proposed back here in 2012 to be a new syndrome because they described 3 families with this autosomal dominant pattern of inheritance. They noted incomplete penetrance, and these patients had gastric polyposis, as well as an increased risk of gastric adenocarcinoma. With this syndrome, the polyposis, they said, had many funded gland polyps with dysplasia. They noted some adenomas and hyperplastic polyps. They said there's a relative sparing, and you can see that here, unlike the photo of the funded gland polyps that were just covering the FAP patient. This particular patient has, this is the distal part of the stomach with the antrum here, and this area has no visible polyps, whereas here in the proximal portion with the fundus and in the body, you can see there are innumerable polyps. In this patient, there was sparing of this lesser curvature. And here are some of the polyps they saw in their study. These patients were found later to have a point mutation in the APC promoter 1B. They looked at those 3 originally reported families, as well as 3 new families they identified in North America. And with this promoter mutation, they note that there are families who have FAP who also have this mutation. And so they proposed it was a variant of FAP. And in the most recent chapter of the WHO, they actually wrote the chapter and now consider it to be a special variant of FAP. What's interesting is that they went back and retrospectively looked at the histology more closely. And this is one of their tables in what they published. And they say that, interestingly, funded gland polyps were not seen in all cases. These are the biopsies under gastrectomy. And even they say among 4 out of 5 did not had funded gland polyps, meaning 1 did not. And it seems to be maybe it's because of their definition where they wanted to see well-developed cysts in a funded gland polyp. They describe what they call a hyperproliferative aberrant pits, or HPAPs. These they describe as being disorganized proliferations of exinthic glands that involve attenuated foveolar pit region. And they noted some had funded gland polyp-like changes. And because they saw it most commonly within these polyps, they thought it might be an early pathologic finding. They don't really describe whether patients had no funded gland and no HPAPs. They don't really clarify how often it is that you'll find a patient who has this point mutation who does not have any funded gland polyps. But this does seem to indicate that some patients may present without funded gland polyps. These are the HPAPs they describe. They actually look, they have features of funded gland polyps. If you look closely at funded gland polyps just outside this setting, they have the features described here with these HPAPs. You'll see disorganization of the exinthic glands. They sort of bump up very close to the surface. Although we really focus on the cystic dilation, there are other changes within funded gland polyps, such as expansion of the stroma and this disordered appearance with the exinthic glands sort of bumping up very close to the surface. And Henry Appelman likes to talk about that a lot. So I found it interesting that in this study, they decided that this was a new sort of a lesion. And really, it's sort of a funded gland polyp that doesn't have cystic dilation. But regardless, they included that here in this WHO criteria. So this is essentially the same as what they proposed back in 2012, but with a little bit more refinement here. They have the essential criteria being phenotypic features of either of having proximal gastric polyposis with the antral sparing and no evidence of colorectal or duodenal polyposis, having greater than 100 polyps. It's an arbitrary designation, but having just a carpet of polyps in the index case within the proximal stomach, or if it's not the index case, but a relative of an index case, then greater than 30 polyps in a first-degree relative. Predominantly funded gland polyps or funded gland-like polyps is included, and presumably these are their HPAPs. The proband or family members should have dysplasias or gastric adenocarcinomas documented, and APC promoter 1B mutation testing. Supportive criteria, they say, are the family history with the autosomal dominant inheritance pattern and a spectrum of histologic lesions, meaning that sort of heterogeneous morphology to the polyps that can develop in these patients with GAP syndrome. Exclusion of other heritable gastric polyposis syndrome should also be done. And also use of PPI, because long-term use can lead to a diffuse polyposis, often with lots of fundus gland polyps. And when taken off the PPI, these can go away on their own. And so if that's the case, they say it should be done after the endoscopy period has been a while after trialing off the PPIs. All right. This is a case here of a woman who had GAP syndrome. At the time of biopsy, it was not known, but you can see both the polyps and intervening mucosa had a lot of abnormalities with cystic dilation. Many of these were fundus gland polyps, and you can see here the cystic dilation and the look of a fundus gland polyp with this disorganized appearance of the glands. Some had low-grade dysplasia, others had an adenoma-like morphology, here with a foveolar type epithelium and low-grade dysplasia resembling a foveolar adenoma. Similar changes were seen in the flat mucosa with fundus gland polyps, some dysplastic, some adenomas. The clinicians decided they couldn't surveillance this patient, so they ended up doing a resection. And you can see here variably sized polyps. Some are small, some are large. Many of them have fundus gland morphology. And even at low power, this dark appearance shows you that there's low-grade dysplasia in areas, and it's pretty patchy. Some areas did not have dysplasia. Poitz-Jaeger syndrome has patients who have an increased risk of cancers, including GI tract. They develop hematomatous gastrointestinal tract polyposis and mucocutaneous pigmentations. In terms of gastric manifestations, polyps develop in about a quarter of patients. And in terms of lifetime risk, about a third of patients will develop gastric cancers. Diagnostic criteria in the WHO actually relies heavily on the histologic diagnosis in patients. They say 3 or more histologically confirmed Poitz-Jaeger polyps, any number of Poitz-Jaeger polyps in an individual with a family history of Poitz-Jaeger syndrome, or any number of Poitz-Jaeger polyps in an individual who also has characteristic prominent mucocutaneous pigmentation. This one here doesn't include the histology, but characteristic prominent mucocutaneous pigmentation in an individual who has known family history of Poitz-Jaeger syndrome. In terms of the genetics, the STK11 and LKB1 tumor suppressor gene mutations are found in most cases. And again, it's an autosomal dominant pattern of inheritance. The Poitz-Jaeger polyps are most easily identified in the small bowel. This is an example with these beautiful arborizations of smooth muscle around these areas of disorganized mucosa. They have all the elements expected of the small bowel, such as lamina propria, crypts, villi, but it has this very distinctive morphology. When it comes to stomach polyps, however, that morphology is not seen well. So here's an example from a patient with known Poitz-Jaeger syndrome. There is this thick area of smooth muscle, but the branching is much more subtle here. And you can see here in this polyp, again, there's a little bit more branching, but not as prominent as the small bowel. And this is just higher power view showing that arborization and normal elements of the gastric mucosa, making this a hematomatous polyp. Some polyps will not have any real recognizable smooth muscle bundles. Similarly, in the colon, the changes may not be well developed. So although the WHO doesn't specify where these Poitz-Jaeger polyps should be, generally speaking, it's the small bowel where they'll be recognized. And really, it's only in the context of recognized Poitz-Jaeger polyps that we can really definitely classify these as Poitz-Jaeger hematomatous polyps in the colon and stomach. But if you see arborization in stomach, at least you can consider the possibility in a patient who has lots of polyps. Where we've seen arborization that's not in Poitz-Jaeger are older patients who have diverticulosis, and oftentimes these will be in the sigmoid colon, and that seems to be one area that can mimic a Poitz-Jaeger polyp in the colon. In terms of the juvenile polyposis syndrome, it's also autosomal dominant in inheritance. There are multiple juvenile polyps that develop in the GI tract. And within the stomach, the majority of patients will develop polyps. Gastric lifetime risk is about 11 to 21%. For this, the WHO also includes histologic juvenile polyps in their diagnostic criteria, so greater than 3 to 5 juvenile polyp in the colorectum, and they're most well developed in the colon with that morphology with cystic dilation and very smooth sort of surface and expanded stroma. Juvenile polyps can occur, though, throughout the GI tract, so that's included in the diagnostic criteria, as well as any number of juvenile polyps with family history, and patients who have a family history of known juvenile polyposis. And other syndromes have been excluded that have hematomatous GI polyps. About 50 to 60% of cases can have identifiable mutations in SMAD4 and BMPR1A gene mutations. And then the loss of SMAD4 can be demonstrated by immunohistochemical staining in patients who have the SMAD4 germline mutation. And that occurs when there's a second mutation within the SMAD4, the other allele. And in studies, it's been shown that polyps can't actually be distinguished histologically very well. And so often, particularly with this juvenile polyposis, it's very difficult or not possible at all to really recognize that they're juvenile polyps because they don't have real characteristic morphology. This is a nice study in which they blindly looked, they first looked to see if they could figure out any sort of histologic criteria that could help distinguish Poit-Jaeger from juvenile polyps from just sporadic hyperplastic polyps. And then they went back at some time later and looked at it again using their criteria. And they said the accuracy was better for Poit-Jaeger, but actually worse for juvenile polyps and hyperplastic polyps. Reason being that some of these juvenile polyps look similar to hyperplastic polyps or foveolar hyperplasias or are fairly nondescript. So their conclusion was that histologic features are really insufficient to distinguish these types of polyps. And really caution should be used if we're trying to propose that possibility in that patient who doesn't have a known established history. One of the other gastric cancer syndromes I wanted to discuss is hereditary diffuse gastric cancer, or HDGC. This is also autosomal dominant with variable penetrance. It doesn't usually present with polyps, but it has increased risk of diffuse type of gastric cancers and development of lobular breast cancers. The reason being that the mutation is a CDH1 mutation, which encodes the ECAT-herin gene. And it creates an inactivating germline mutation. Many germline mutations have been reported, and a majority are truncating, causing loss of function in the ECAT-herin protein, and are considered to be pathogenic mutations. Initiation of tumorigenesis, however, requires that the second copy of the CDH1 also be inactivated, and that can occur through various mechanisms, including promoter methylation. The prevalence is very low, so only less than 1% of gastric cancers can be attributable to this hereditary diffuse gastric cancer. Cumulative risk in one study by the age of 80 for patients who had the CDH1 mutation for diffuse gastric cancer was about 70% in men and 56% of women that they looked at. And in terms of lobular breast cancer, about 42%. Here, we offer surveillance endoscopies. Once you identify one family member, often there are many other family members that are identified through additional testing. Some of our patients, it's been a surprise. They don't have any indication that they might have this mutation, but just on screening with their genetic panels, they discover they have a CDH1 pathogenic mutation. The question is what to do with these patients, as currently it's really not understood what the natural history is. Risk stratification right now is not well understood. So it's unclear which patients will benefit from a prophylactic gastrectomy and when they will benefit from that gastrectomy. So surveillance endoscopies are done with many biopsies being taken from patients. These cancers and polyps can occur, I'm sorry, not polyps, but just the cancer in situ lesions can occur throughout the stomach. So just extensive biopsying is done. But many of these biopsies we see have just normal gastric mucosa without identifiable abnormalities. And patients will still sometimes choose to go for the prophylactic gastrectomy. In those cases, the stomach looks grossly normal. Even though you look at it really carefully, grossly, you can't see any clear abnormalities that correlate with a microscopic lesion. And endoscopically, it will also appear normal. And so it's debated as to how best to care for these patients. They have a very characteristic appearance when they're early. And most of these in prophylactic gastrectomies will have these very small lesions in which they have the signet ring cell carcinoma. It's often very superficial within the mucosa, so near the surface of the gastric mucosa. And they're very small, usually millimeters in size. They're often multiple that you can see throughout the stomach in the random sections. These tend to be sometimes so small that they can't be seen at lower powers if they go to real high power, because there may only be a very small number of signet ring cells in a given focus. At higher power, they have this very characteristic appearance. Unlike the sort of acid, more bluish colored mucin you can see with just general signet ring cell cancers, these tend to have very pink cytoplasm that is reminiscent of the pit cell cytoplasm. They look very similar. And then they have eccentrically placed nuclei and a very sharp cell border with these very nicely darkly defined outlines of pink. And they're somewhat irregular in shape, but they're fairly large in size. And so this sort of a look is very characteristic of what we've seen in these patients who have prophylactic gastrectomies or have surveillance biopsies with incidentals or just small cancers that are discovered microscopically. As they go in deeper, though, I've noticed that these tend to have more of a characteristic diffuse type pattern with less cytoplasm, less mucin, a little bit harder to distinguish as they get down a little bit deeper from the other types of poorly cohesive type gastric cancers occurring outside the hereditary setting. The in situ lesions can be identified in these patients. This normally can't be done in patients with diffuse type cancers that are not CDH1 mutation related. Those we don't see background lesions. But in these patients, if you look closely, you can usually find within the gastrectomy and sometimes within the biopsies these in situ lesions. And the most recognizable form is what they call the pagetoiding morphology, in which you have a pit here, and these are the normal non-neoplastic foveolar pit epithelium, normal nuclei here, and there's a second layer of cells beneath the nuclei, and they have a somewhat disordered look to them. Here's a cross-sectional view showing again the foveolar pit cells with the gastric carcinoma cells here right at the opposite end here, the basal aspect of the of this glandular pit here. And so this is a very characteristic morphology here. It looks like it's almost sort of crawled out and possibly has invaded into the lamina propria. They have described another in situ lesion, which they distinguish as pagetoid versus in situ. And this is not so reproducible. In this one, the cells that are thought to be the precursor lesions or the in situ lesion just has a jumbled appearance. They are a little bit larger than the background cells, a little bit rounder. But if you look carefully, it can get quite confusing because sort of jumbling and this architectural abnormality can be seen in the mucous neck areas. So this area, if seen, I think is a lot more difficult to decide if it's truly an in situ lesion or not, whereas this is more distinctive. Finally, I wanted to talk about Cronkite syndrome. It is not an inherited syndrome, it's acquired. And it was first reported by doctors Cronkite in Canada in 1955. And in their patient, they noted that there were these areas within these radiographic panels here where you can see these defects. And this was due to mucosa that was polypoid pushing in towards the lumen. And you can see it throughout the GI tract here. Patients will present with various symptoms, including diarrhea and weight loss, and abdominal pain, malnutrition, or peripheral edema. And most patients are older, greater than 50 years of age, average 60. This is of uncertain etiology, but some propose it may have autoimmune etiology, as there's some response to immunosuppressants such as corticosteroids, and increased IgG4 cells have been observed in some cases. These patients have progressive malnutrition because they're unable to digest their food and absorb it. And so their prognosis is poor, with complete remission in less than 5% of patients and a 5-year mortality rate of 50% due to usually complications such as GI bleeding and sepsis or other complications. Malignancies in this setting right now is somewhat controversial. There have been reported cases of malignancies, including gastric cancers, that have developed in patients with this Cronkite Syndrome. And so some think there is some degree of malignant potential in these patients for gastric cancers to develop, whereas others feel that there really isn't, and this was just a coincidental finding. So at this point, it's not entirely clear what risk patients with Cronkite Syndrome have for developing gastric cancer, but they do have a lot of other issues for which probably mortality will be attributed to other complications rather than gastric cancer. In terms of the clinical, the GI tract can have a lot of polyps, usually with esophageal sparing. And so these are gastric polyps here, ectodermal changes, including nail issues of onychodystrophy, alopecia, and cutaneous hyperpigmentation. And in terms of the polyps that can be seen, they have really interesting morphologies. They're broad-based. They have a hematomatous appearance, according to some people, in which it's a very disorganized appearance, so with lamina propria that's inflamed and edematous. And you'll see similar changes whether you biopsy the polyps or in between the polyps of what looks endoscopically more flat. And so this is a case we had here of a patient who had stomach nodules, duodenal nodules, and all of these mucosal biopsies look very abnormal with strange architecture on the surface, loss of the villi, really expanded lamina propria that's edematous and inflamed. Just very strange morphology, no dysplasia, but cystic dilation present in many of these gastric biopsies. And this very strange morphology did turn out to be a Cronkite Syndrome. They had similar findings in the duodenum, where there's loss of villi, expansion of the lamina propria with inflammation and edema, and similar changes in the colon. So it's something to consider when there's polyposis in the stomach of a patient. And that is the conclusion of my lecture, and I'll take any questions. Thank you.
Thank you so much, Dr. Choi. This is an amazingly comprehensive presentation of the topic. We thank you for the beautiful pictures. Particularly, I'm interested in highlighting the various morphologies of gastric cancer, because we, in surgical pathology, as you know, we encounter metastases from unknown primary, and when we land on a primary gastric, it's very difficult because the spectrum of morphology is very wide, and as you demonstrated quite clearly, that some of these cancers could be very early and there is no mass or not much symptomatology that direct us to the stomach. So thank you for highlighting the various morphologies. I'm just interested in knowing whether gastroenterologists or oncologists in your institution would subscribe to putting an advanced gastric cancer patient on Herceptin when HER2 is negative. I know you mentioned that it should only be given to HER2 positive patients, but sometimes the patient is desperate, and there have been claims out there that some patients may benefit from Herceptin even if they were HER2 negative. Is that something that you encounter in your practice?
I haven't encountered that yet, but I haven't specifically asked our clinicians, and they've not asked us. So I don't know what they do. We've had some that are equivocal on fish, and I don't know what they decide to do for those. They've come back, and I know in the breast cancer HER2 interpretations, if fish is equivocal, they go back to the H&E and look to see if they can decide whether, or I'm sorry, the IHC to decide if it's positive or negative. We don't do that as there's no precedence. And so in those cases, I'm not sure if the clinicians decide to go and treat them anyways, to give them a chance or not. So yeah, that's interesting. I haven't been specifically asked that.
Any more questions or comments for Dr. Choi?
Mahmoud, I might just make a comment on your question, Dr. Choi's response. So there's a company in town called Celcuity. I'm actually on their board. They have an electrophysiological way to test drugs on primary tumor cells. They're working primarily on breast and HER2 negative. And it's an impedance methodology. So it deals with the cell shape and junctions or whatever between the cells. So what they can do is when they put a drug on, that the cell responds to it, change its shape. And an electronic signal is far more sensitive than anything we use. And they find about 20%, and they're in a big clinical trial now with, this is public, with Genentech, but about 20% of so-called HER2 negative breast tumors, when you do this type of assay, actually show an in vitro response to Herceptin. So what it may do is open up a whole host of patients with different, and HER2 is around a lot of places, as you know. It may open up a chemotherapy option for these patients that heretofore have not been treated. So it's quite exciting.
Oh, that is very interesting. Thank you for sharing.
Yeah. I have a quick question. I'm not sure we have enough time for it. So do you want me to ask that when
We can save it for our meeting with Dr. Choi.
with Dr. Choi? With Dr. Choi, thank you very much. That was quite an interesting talk that we all enjoyed very well. So
Thank you.
Dr. Choi agreed to spend some time with the residents, so we don't want to be taking their time. Thank you very much.
Thank you.
Thank you, everybody.